November 14, 1967. 3rd Field Hospital, Saigon. A captured North Vietnamese army soldier arrives on a stretcher, chest wound sucking air through torn tissue. Triage nurse checks vital signs first, not identification papers. No interrogator waits at the door. Priority 1 status means the operating room opens before any question gets asked. Chlorine sting, Ward 3, 3rd Field Hospital. The assumption in 1966 runs like this. Wounded enemy combatants get patched up in holding cells, then face intelligence officers who extract tactical information. Hollywood scripts and wire service reports show the same sequence across Korea and World War II. Interrogation precedes surgery. Geneva rules apply only after the urgent questions receive answers from captured personnel. The 1949 Geneva Conventions establish one non-negotiable rule. Medical need determines treatment sequence, nothing else. Article 12 defines the standard wounded prisoners of war receive care identical to a captor's own forces, no exceptions permitted. No distinction by nationality, no delay for intelligence value, no triage category labeled enemy anywhere in the protocol. The United States Military Assistance Command Vietnam publishes MACV Directive 2005 in 1965, codifying Priority 1 through Priority 3 status across all medical facilities. Priority 1 means immediate surgery within 2 hours. Priority 2 allows stabilization within 4 hours. Priority 3 permits delayed care within 24 hours. A wounded NVA officer with a severed femoral artery ranks Priority 1 alongside a wounded Marine with identical injury severity. This priority ladder defers interrogation until physicians' authorized transfer medical chain overrules intelligence chain. The International Committee of the Red Cross monitors compliance at 7 major facilities. 3rd Field Hospital in Saigon, Long Bin, Da Nang, Chu Lai, Quy Nhon, Cam Ranh Bay, plus 2 hospital ships, USS Repose and USS Sanctuary, operating offshore. Triage nurses carry no security clearance. Surgeons operate blind to prisoner status until anesthesia wears off. Intelligence officers wait in separate wings, sometimes for days. Geneva trumps tactical advantage every time. March 1967. Long Bin Army Hospital. A captured Viet Cong cadre arrives with shrapnel wounds across his abdomen and left leg, bleeding heavily from multiple penetration points. Triage assigns Priority 1 status within 90 seconds of helicopter touchdown. The operating room receives him 47 minutes later. No translator accompanies him into surgery. No intelligence officer reviews his case beforehand. One surgeon later recalls, "We didn't know his name, didn't know his unit. The bleeding determined everything." Blood transfusions total 6 units during a 3-hour procedure that repairs damaged intestinal tissue and removes shrapnel fragments. Post-operative recovery places him in the same ward as 2 Americans and 1 ARVN soldier, all recovering from similar blast injuries. An intelligence officer arrives 38 hours later, after the patient regains full consciousness, and nurses confirm stable vital signs meet discharge criteria. The ICRC delegate reviews the case file in April 1967, noting 0 protocol violations across 14 pages of documentation. The cadre's medical record contains surgical notes, anesthesia logs, and nursing assessments before any interrogation transcript appears. His debrief, conducted through an interpreter in May 1967, reveals shock at the sequence. "I expected questions first. Instead, American hands stopped the bleeding." The inversion extends beyond one case at Long Bin. The facility processes 600 POW admissions between 1966 and 1970, each following identical triage rules without exception. Priority status overrides origin every time. A priority. 2 enemy soldier receives surgery before a Priority 3 friendly soldier. No debates permitted. The contrast becomes doctrine. No interrogator reviews a patient chart until the attending physician signs a discharge or stabilization order authorizing transfer. One captured NVA medic, treated at Quy Nhon in August 1968, later states during debriefing that he counted 4 U.S. soldiers and 2 NVA personnel in adjacent beds within the same recovery ward. The ward arrangement communicates policy louder than any briefing document or training manual ever could. While enemy propaganda claims brutality, the surgical logs show identical care protocols, not ideology, but triage. June 1968, Da Nang Naval Hospital. A captured NVA officer with a collapsed lung and fractured ribs arrives via medevac helicopter, respiratory distress visible in labored breathing patterns. The chest tube insertion happens 11 minutes after arrival. Emergency procedure executed without delay. No security detail enters the trauma bay during the procedure, despite the patient's suspected senior rank. One trauma nurse later recalls, "His rank didn't register until afterward. We saw the respiratory distress, and that's what we treated." The officer's lung re-inflates within 20 minutes of tube placement. X-rays confirm proper positioning, and he transfers to intensive care for continued monitoring. An ARVN liaison officer requests immediate access for questioning about recent operations in Quang Nam province. The attending physician denies the request, citing medical instability and ongoing oxygen dependency requiring constant supervision. The officer remains under observation for 72 hours before any intelligence interview occurs. His file records 9 separate medical interventions, chest drainage adjustments, antibiotic administration, pain management protocols, before the first interrogation session begins. The Da Nang facility treats 240 POWs during 1968 alone. Every case follows the same sequence: stabilize, then question, never reversed. Rotor thump fades. Da Nang Pad 2. One U.S. Army interpreter, stationed at Da Nang in 1967, waits an average of 54 hours per case before receiving clearance to enter patient rooms for debriefing sessions. He later states, "We sat in the hallway, sometimes for days. The doctors ran the show, not us." The delay frustrates field commanders who demand tactical intelligence immediately after capture. MACV reaffirms MACV Directive 2005 in a classified memo dated October 1968. Medical care precedes all other considerations, no modifications authorized. The priority system tolerates 0 exceptions regardless of operational urgency. A Priority 1 enemy casualty displaces a Priority 2 friendly casualty from the operating schedule if resource constraints limit simultaneous procedures. While battlefield commanders demand intelligence access, hospital protocols remain unchanged throughout the war. Not urgency of questioning, but urgency of care. January 1969. USS Sanctuary, South China Sea. A captured Viet Cong fighter with burns covering 30% of his body arrives by helicopter transfer from a shore-based aid station. The ship's burn unit receives him directly onto specialized treatment beds. Debridement and fluid resuscitation begin within 25 minutes of deck touchdown. No interrogation team exists aboard the 2 hospital ships operating under strict Geneva neutrality provisions. The chief of surgery later recalls, "Sanctuary was a hospital first, a Navy vessel second. Geneva rules applied the moment a patient crossed the deck." The burn treatment spans 11 days before the patient stabilizes enough for shore transfer to a POW detention facility. His medical record fills 22 pages during shipboard care, hourly fluid balance, charts, skin graft procedures, infection monitoring protocols. 0 interrogation notes appear anywhere in the file. The Sanctuary and her sister ship, Repose together, treat 800 POW cases between 1966 and 1970, all under identical medical-only protocols. The ship's neutrality under Geneva rules means no armed guards accompany prisoners within designated medical spaces. One Navy corpsman recalls a moment in 1968 when a wounded NVA soldier and a wounded Marine occupy adjacent recovery bunks, separated by 4 feet of deck space. The corpsman administers pain medication to both patients within a 5-minute window. The Marine asks why the enemy receives the same morphine dosage. The corpsman explains the Geneva rules in simple terms. The Marine says nothing else, but later tells a chaplain the policy makes sense because pain doesn't pick sides. The hospital ship model removes tactical pressure entirely from medical decision-making. No field commander can access a patient at sea without ship's captain approval. The commanding officer answers only to Geneva compliance officers and naval medical chains, not combat intelligence units. One ICRC inspector visits Sanctuary in March 1969, documenting full adherence to Article 12 standards across all reviewed cases. While shore facilities face daily pressure from intelligence units demanding earlier access, floating hospitals operate beyond that reach by design and distance. Not accessibility to interrogators, but inaccessibility by design. October 1967, Quy Nhon Army Hospital. A captured NVA medic arrives with a gunshot wound to the shoulder and significant blood loss from arterial damage. Triage assigns Priority 1 status immediately. The operating room opens 31 minutes after his arrival, standard timing for life-threatening hemorrhage cases. The surgeon discovers fragmented bone requiring extensive debridement and vascular repair beyond initial field assessment predictions. The procedure lasts 4 hours and 15 minutes. Post-operative care includes 8 units of blood transfusion, matching the protocol for any American casualty with similar injuries and blood loss volume. The resource allocation follows established formulas, not nationality considerations. One head nurse later recalls, "We tracked blood pressure, not allegiance. The monitor showed numbers, not nationality." The medic remains in intensive care for 6 days due to infection risk and continued vascular monitoring requirements. An intelligence officer submits 3 separate requests for interview access during this period. The chief of surgery denies all 3 requests, citing post-operative complications including fever and wound drainage requiring continued isolation protocols. The medic's first interview occurs on day 9, after full wound healing begins and fever subsides completely. His debriefing transcript, declassified decades later, includes his statement, "I trained in field medicine under the assumption of capture and execution. Receiving transfusions instead rewrote my understanding of the Americans." Quy Nhon processes 320 POW admissions between 1966 and 1969. The facility's statistics show identical mortality rates for POW and US patients within the same triage categories. Priority 1. Cases survive at equivalent rates regardless of uniform. Priority 1 POWs receive the same resource allocation operating room time, blood products, intensive care bed days as Priority 1 US personnel without reduction or delay. One declassified after-action report from 1968 notes that 4 captured NVA soldiers survive wounds that prove fatal to 3 ARVN soldiers during the same week, the difference attributed to timing of helicopter evacuation from battlefield, not differential care after arrival. The data confirms that triage category determines outcome, not origin. The policy faces 0 official challenges during the entire war, despite tactical objections from field intelligence officers. While some commanders privately argue for interrogation priority, the medical chain never yields authority. Not politics over protocol, but protocol without exception. The perception break spreads unevenly across both sides. Captured combatants expect torture or intentional delay before treatment, not immediate blood transfusions matching American casualty care. American medical personnel enforce Geneva rules without internal debate, while intelligence officers wait outside locked ward doors. The inversion of expectation creates ripples on both sides of the conflict throughout 1967 and 1968. North Vietnamese propaganda warns soldiers that capture means interrogation under duress before any medical attention reaches wounded prisoners. Returned prisoners contradict this narrative when they reach Hanoi after prisoner exchanges. One repatriated NVA lieutenant, debriefed in 1969 after a negotiated swap, reports receiving emergency appendectomy surgery at 3rd Field Hospital within 6 hours of capture, no questioning beforehand. His account circulates among NVA units in I Corps by late 1969, passed through unofficial channels and private conversations. The contradiction undermines official propaganda more effectively than any leaflet drop or loudspeaker broadcast ever achieves. Direct testimony from returned soldiers carries credibility that external messaging cannot match. American personnel experience a different surprise on the ground. Field medics and combat troops assume the system bends for tactical intelligence value when high-ranking captures occur. It does not bend, not once. One Army chaplain stationed at Long Binh in 1968 observes wounded U.S. soldiers, delayed for surgery, while Priority 1 NVA patients enter the operating room first based purely on injury severity scoring. The chaplain later recalls, "I watched men struggle with it. The rules said Priority 1 goes first, no exceptions. Accepting that meant accepting the principle mattered more than the uniform." The policy's enforcement relies on medical chain authority exceeding tactical command structures throughout Vietnam. Hospital commanding officers report directly to MACV Surgeon General, bypassing intelligence hierarchies completely. This structure insulates medical decisions from battlefield pressure and operational demands for information. The separation proves essential to consistent enforcement. The ICRC conducts 34 documented inspections across all facilities between 1966 and 1970, reviewing patient records and interviewing staff members. 0 major violations appear in the inspection reports released decades later. Minor discrepancies, delayed patient transfers between facilities, incomplete record-keeping in field hospitals receive corrective action within weeks of identification. The compliance rate reaches 98% across all sampled cases during the peak war years. One ICRC delegate stationed in Saigon from 1967 to 1969 later writes in published memoirs that U.S. military medical facilities in Vietnam set the standard for Geneva compliance in modern conflict zones, surpassing World War II and Korea records. The assessment comes from direct observation across hundreds of site visits. The motif of care preceding questions reshapes perceptions incrementally, case by case. Captured personnel learn the system protects them identically to U.S. casualties, not through promises, but through consistent application. The trust built through this consistency affects post-war narratives in unexpected ways. Declassified interviews with repatriated POWs from the 1970s and 1980s consistently mention medical treatment as a departure from Communist Party training and expectation. One captured VC political officer, treated at Cam Ranh Bay in 1968 for multiple fragmentation wounds, states decades later in a Vietnamese historical interview, "The surgery came first, questions later." That sequence contradicted everything we were told about American interrogation priorities. The policy's psychological impact extends beyond individual cases to systemic perception shifts. It signals commitment to rules over expediency under battlefield conditions. American medical personnel internalize this principle as core professional identity throughout their service. Decades after the war ends, veterans of these hospitals describe the triage system as proof that law functioned even in chaos, that principles survived operational pressure. The contrast with other wartime practices amplifies the significance of consistent compliance. While My Lai and other documented atrocities violate international law catastrophically, the medical triage system upholds Geneva standards without deviation across thousands of cases. The juxtaposition matters historically. Not universal compliance across all military operations, but consistent compliance within medical spaces where authority structures protected the protocol. The practice continues without modification until the last U.S. medical units depart Vietnam in 1973. No policy revision alters the Priority 1-2-3 system during the entire war period. Whitesheet Russell, Ward 7, Long Binh. Post-war analysis by the U.S. Army Medical Department credits Geneva-compliant triage with preventing international legal challenges and maintaining Red Cross cooperation throughout the conflict. The system's success relies on pre-delegated authority. Hospital commanders hold power to refuse non-medical personnel access to patients, exercising it routinely without requiring case-by-case approval. The precedent influences U.S. military The medical doctrine in subsequent conflicts for decades. Desert Storm, Iraq, Afghanistan all adopt updated versions of the same priority-based triage system. The Vietnam-era protocols become standard training doctrine at Fort Sam Houston by 1975. The principle survives because it proves operationally sound. Treating wounded enemies according to medical need avoids legal complications and maintains international legitimacy. Geneva precedes interrogation across 7 facilities and 2 ships over 5 years of peak operations. The rules, enforced through protected command structures, reshape reality on the ground. Rules before revenge. Care precedes questions. Triage by injury severity, not identity or intelligence value. The stretcher reaches the operating room before the interrogator reaches the door, every time. Geneva first, always.